Good afternoon. Welcome to my study where I sit and bask in glorious isolation with my positive COVID test sitting on the table next to me. It's a bit of a challenge for us with me not being in the studio because it makes the technology that little bit more awkward to operate, but I'm sure you're going to enjoy this afternoon's show just the same because I am joined by some very eminent people. Obviously, you know that, that's why you're here. I've got Simeon Niel-Asher, who is an osteopath, eminent in his own right as an osteopath, but he's also well known for his frozen shoulder treatment and the connected hip treatment, which he's demonstrated on courses, but also for all the work that he's done on trigger points. Joining him, though, he pales into insignificance next to Professor Bob Gerwin, who is a professor of neurology at Johns Hopkins in Baltimore. The two of them have run a course for us here in the UK, I think it was November last year, which was incredibly popular. It was such a good course, and we'll talk about that a little bit later. But today we're going to be, well, I'm not sure what we're going to be talking about, because I was told it was going to be anterior interosseous syndrome, and now it seems to have morphed into that plus all sorts of other things. Simeon, what are we going to be talking about? And welcome.
Well, thank you very much. Well, thank you for inviting us, and it's always lovely to share the platform with Dr. Gerwin. I would tell you now that he's my guru, and when we did the course together, they say never work with children or animals, on TV, and I never work with your guru because I always feel a bit nervous around him. Nevertheless, we're going to talk a little bit about trigger points and how they relate to sort of nerve, the relationship with nerve or sort of neurology. I think I was just going to introduce how I came to meet Bob and how I got into the whole sort of trigger point story. So I've been qualified 30 years now. So in my second year at university, I had the great fortune of working, one of the professors took a shine to me, and he started to teach me about trigger points, which were fascinating. I didn't put a needle in them really for many years until I met Bob. So this was sort of manual therapy of trigger points. And I remember we had a patient came to the clinic, and I was so excited. I did this deep sort of myofascial release on her sort of iliotibial band, lateral quads. And she came back the next week, black and blue from her hip to her knee. And I thought, oh God, that isn't good. So I suddenly realized that actually these trigger points, this deep myofascial stuff isn't quite so simple. And I refined my technique, I'm happy to say, no more bruises. And for many years, I was using manual techniques, really. I had the great fortune of going to one of Dr. Gerwin's courses in the UK, but I didn't really talk to him very much. We sort of briefly spoke after. He was a little bit more austere in those days. And then he came to Israel. I have a clinic in Israel. And we ended up doing a workshop together, and we've taught on workshops since. And listen, when I saw the phenomenon that Dr. Gerwin did of putting a needle in a trigger point, and you've got to understand, I'm pretty into trigger points. I've written books on them, and I've taught courses on them, and my whole shoulder technique's a trigger point. When I saw that muscle twitch with the IMS, something just I couldn't quite believe what was happening. I thought there's a whole system that's never.
Just let me interrupt you for a second, Simeon, because you said IMS, intramuscular stimulation. Yes.
Correct. Yeah. And again, we'll talk a little bit later about the difference. So I attended Dr. Gerwin's course, and then we ended up teaching together. And I've ended up. I started working on my sort of interactive sort of 3D software, and I already sort of had come quite a way forward. And I remember we went for lunch on one of the courses. I was very excited to show Bob what I was doing, and he loved it. And he said, "Listen," he said, "could you put videos in it?" I said, "That's one of the plans." So we got our heads together, and we put on these highly very well recorded 4K videos in the software. So that's how I met Dr. Gerwin, and really I'm very pleased to say we work really well together, and it's really
I'll tell you what, I don't think we need to big up your credentials or Bob's, to be honest, because we apparently maxed out the server with people joining us for this particular webinar. webinar. Hopefully that's all ironed out now and everybody's got back into the system. But clearly there are lots and lots of people who want to listen to the two of you. My initial question was, what are we talking about? Is it anterior
So
interosseous?
that brings me. Thank you. Yeah, that brings me to the subject. So Bob and I were talking about, what we might share today. And I've been on a few of Bob's neurology conferences where he talked very interesting about the relationship between nerve pain, nerve compression, myopathic compression, and we got thinking about the median nerve and some of those conditions. And Bob, being a neurologist, has a very interesting ideas about how the neurology and trigger points relate. So I'm gonna hand it over to Dr. Gerwin.
Well,
Bob,
thank you
welcome.
both. It is a pleasure to join you, Simeon and Stephen. It is interesting to hear how different people came to have some familiarity and interest in myofascial trigger points and in the whole concept of myofascial pain syndrome, and then add it to what they've already known about the management of the variety of kinds of pain. And this is true with my own background as I would say, an orthodox neurologist practicing regular neurological medicine, but being rather flummoxed by a number of different kinds of problems that classical neurology couldn't answer. I remember one young lady with neck pain, had no idea what she had. I gave her some kind of treatment, which clearly didn't work. And it was years later that I found out that, thinking back, that she really had a myofascial trigger point problem in her sternocleidomastoid. But at the time, I had not the faintest idea. I happened quite by accident to meet Janet Travell. And when I was introduced through her to the whole concept of myofascial pain syndrome and myofascial trigger points, sort of like a light turned on. And I could see many of these neuromuscular pain syndromes that were very difficult to understand became understandable. And
Bob, I'm hoping that nobody who's watching needs to be told who Janet Travell is, but she's a bit of
I'm sorry. I was going to talk a little bit more about her a little bit later,
No,
but
they shouldn't
very
know who
shortly,
she is.
in brief, Janet Travell was President John F. Kennedy's White House physician. When she was in private practice she was a professor at Cornell University Medical Center in New York City. And she had an office for private practice, walk down below street level office on 12th Street in Manhattan. And a friend of hers, a physician friend, came in with a U.S. senator who had not been able to attend the Senate meetings for 7 months. John F. Kennedy hobbled into her office and he walked out afterwards. And that began a long-term friendship. She was invited down to the family compound in Florida to treat him. And when he was elected president 5 years later, he asked her to be his White House physician. She was the first woman White House physician and the first civilian White House physician, which did not make her beloved among the Admiralty. Traditionally, medical care for the president was provided by the naval medical staff, the admirals in the National Naval Medical Center. But she became her name became well known because of that. She moved from New York to Washington, and I happened to meet her quite by accident because I happened to move across the street from a dentist who was teaching about facial pain to dentists and had asked Janet Travell to lecture to these people. And he asked me to join, and I met Janet Travell that way. And she became my mentor. And what I found was that uh, there are a considerable number of neuromuscular syndromes and neurologic conditions, including migraine, headache, and we can talk about this a little bit later, but migraine, radiculopathy, peripheral nerve disorders that were either resistant to normal treatment or difficult to understand and diagnose. And I very quickly saw from my contact with Dr. Travell that the concept of myofascial trigger points, and particularly the concept of referred pain from trigger points, was extraordinarily helpful in understanding these neuromuscular and chronic pain syndromes. As we thought, Simeon and I, in talking about this, we thought that a good way to illustrate that relationship would be to talk about entrapment neuropathies and see the relationship of myofascial trigger points to entrapment neuropathies. And the reason for that relationship comes from the fact that myofascial trigger points uh, uh, exist in muscle that has developed an abnormality in which there is a well-defined tight or taut, T-A-U-T, taut band of muscle. We say a contracted band of muscle, but I think that's not true. I think it's edematous. But in any case, it's a hardened band of within muscle that prevents the muscle from lengthening. But it also means that that muscle is shortened and that muscle can constrict and compress other structures. And the one structure, of course, of interest to me as a neurologist is the compression of nerve. So clearly, nerve entrapment can occur from a mass of any sort, whether it's a bony mass from arthritis or a tumorous mass, an inflammatory mass. But what is most common, I think, is a constriction of the nerve by an overlying muscle. So in considering nerve entrapments as an example of a relationship between myofascial pain trigger points and entrapment syndromes, the median nerve entrapment syndrome comes immediately to mind because carpal tunnel syndrome is the most common entrapment syndrome that we encounter. Carpal tunnel syndrome itself is not a median nerve entrapment by muscle. It's an entrapment in the carpal tunnel at the wrist, where the median nerve passes under the flexor retinaculum or carpal tunnel ligament in association with 9 tendons to the muscles in the hand. And the nerve, which is rather superficial in this, is easily compressed when the tunnel becomes tight for a variety of reasons. Pregnancy, which causes swelling, diabetes, hypothyroidism, a number of conditions, rheumatoid arthritis, can all lead to compression of the median nerve at the wrist in the carpal tunnel. But the intriguing thing to me, as I learned about myofascial trigger points and entrapment, was the fact that you can have a median nerve entrapment in the forearm as the nerve passes in close proximity through the two heads of the pronator teres muscle. And this presents a picture which can be mistaken for carpal tunnel syndrome, but it also not infrequently occurs in conjunction with the carpal tunnel syndrome. You can call it a double crush if you want to use that terminology, where the nerve is entrapped at two or more places, double crush in two places. And it explained why some people who had carpal tunnel syndrome and were adequately treated for carpal tunnel syndrome never really cleared completely, still had symptoms. And that is because they had a median nerve entrapment, which was proximal further up the arm to the carpal tunnel or to the wrist. And that had been overlooked. And that was fascinating to me to discover that, because that is something which is actually rather easily treated if you could identify the problem. And if you had some idea how to palpate muscle. So just very quickly to show you some of the anatomy of what we're talking about, I'll show you a slide of the hand dermatomes, because the first symptom of median nerve compression at the carpal tunnel is usually pain in the hand, in the wrist, and if it continues to get worse, the pain may go up the forearm into the shoulder. But there is a sensory abnormality, which is tingling initially, paresthesias, abnormal sensations in the part of the hand which is innervated by the median nerve. And that is the thumb, or part of the thumb, the index finger, the long finger, and the radial half of the ring finger. So the localization of the sensory abnormality is diagnostic for median nerve and separates that from the ulnar nerve, as you can see in this diagram. And when please.
It's just I've always puzzled about this, and having an eminent neurologist on the show is great, because just how well defined are those dermatomes? We always draw them with nice distinct lines halfway down a finger and so on, but presumably there is variation between individuals.
There is some. There's some cross innervation between the ulnar nerve and the median nerve, but that's actually rather rare. And from a practical point of view, when you actually identify sensory loss as opposed to paresthesias are not that well defined, but sensory loss is very well defined. And it is highly useful to take a pin and ask an individual if the pinprick is as sharp on the radial half of the ring finger compared to the ulnar half of the ring finger. That is extraordinarily reliable test, and very simple to do. That really is very useful in identifying the sensory loss. The other feature in carpal tunnel syndrome in terms of sensory loss, and we'll repeat this when we summarize this at the end of this presentation, but the innervation of the skin over the thenar eminence, over the base of the thumb, The nerve for that does not go through the carpal tunnel, so that in carpal tunnel syndrome, there is generally no sensory loss in the thenar eminence. The sensory loss is confined largely to the half of the to the palmar surface of the thumb, to the index finger, long finger, ulnar half of the radial half of the ring finger, and the distal portions of the dorsal surface of these affected fingers. So from a sensory point of view, you can pretty well identify uh, abnormalities caused by uh, compression of the sensory nerve as it or the sensory component of the median nerve as it goes through the wrist. Now, other features, diagnostically speaking, are to tap the nerve. If you tap an injured nerve with a percussion hammer, uh, it reproduces, it induces the paresthesias and pain. So you tap the volar surface of or the palmar surface, if you will, of the wrist. A technique called the TNAT sign, and you will get the reproduction of tingling electric shock into the fingers and local pain. And then if you bend the wrist, if I can show this, you can bend the wrist, uh, uh, compressing the median nerve at the wrist, Phelan sign, and again, you hold that for 30 seconds or so, and you induce tingling in the affected hand. So these are diagnostic signs that help you identify a median nerve compression at the wrist. Uh, there are other diagnostic studies. The most useful one is electro diagnostic testing, but the patients become symptomatic well before electrodiagnostic testing can identify slowing of nerve conduction through the carpal tunnel. Now, the interest in the pronator teres muscle comes because the median nerve passes between the two heads of the pronator teres muscle. So now the pronator teres muscle has a humeral head, which arises from the medial epicondyle of the humerus and then inserts on the radius. The other head, the humeral head, by the way, is the largest head and more superficial. The deeper head of the pronator teres is the ulnar head, which originates proximally on the ulnar bone, on the ulna, and then attaches to the radius just below the supinator muscle, and then the humeral head attaches just below the ulnar head of the pronator teres muscle. So there are two muscles that are distinct that both have the function, and you can see for yourself if you have fixed the ulna and the humerus and you contract the pronator teres muscle, you're going to roll the radial bone or the radius over and medially to the ulna, and you'll pronate the forearm, the wrist, and then the hand. So, and which now the pronator teres is not the major pronator muscle. The pronator quadratus in the wrist is, but it is a potent assist to the pronation of the forearm. But the main point here is that there are two heads, and there's a space between them. And the median nerve passes between the humeral head and the ulnar head of the pronator teres muscle and can be entrapped.
Well, I
Now,
think Steve has a question.
please.
Yeah, I'm sorry, Bob. I don't. I hate to interrupt your flow because it is fascinating stuff, and everybody will be absorbed by the detailed anatomy, which is hugely interesting. But ages ago, Trish sent in a question about dermatomes, and I wanted to put it to you before we move too far on from that. She said that she'd always thought that distal symptoms were more serious than proximal within a dermatome. Is that true?
The distal symptoms more proximal. Well, the hand doesn't have. You're talking about fingers and the palm. I think the paresthesias. First of all, the dysesthesias and paresthesias are much more typically found in the fingers, which are more active in terms of sensation than the palm of the hand in any case. Pain into the palm of the hand and into the fingers is a significant finding regardless. But yeah, I think that that's an interesting question, and I think worthwhile to make the point that the paresthesias and dysesthesias are primarily found in the fingers. You don't expect them so much in the palm. But I think that when you're talking about sensory changes in the palm of the hand, uh, you again have to be aware when you're testing the hand that the thenar eminence is innervated. The skin is innervated by a nerve that does not go through the carpal tunnel. However, that nerve to the hand actually is part of the median nerve as it goes between the two heads of the pronator teres muscle. So the pronator teres muscle can compress the median nerve when there is a trigger point in either the ulnar or the humeral head, contracting the muscle, or in both heads for that matter, narrowing that space, and so that when you then activate the muscle and bulk up that muscle by pronating the forearm, the median nerve becomes compressed repeatedly. If you're doing an activity, for example, like turning a screwdriver, or repeatedly turning pages in a book or a manual, so that your forearm is repeatedly pronated, and then you get symptoms of pain, usually in the volar surface of the forearm, uh, down into the hand and into the fingers. If the compression of the nerve, the median nerve in the wrist, goes on long enough and is severe enough, you'll get weakness of muscles, particularly of the flexor pollicis brevis. That's the short flexor of the thumb, and the opponens pollicis. So that the test for this weakness is to attempt to touch the tip of the thumb to the tip of the small finger, and then you can, with the examiner, can pull their index finger through that circle, and if there's weakness in these muscles, you'll find that the thumb and little finger can be easily separated. Normally, it's difficult to do. When there is compression of the median nerve as it passes through the pronator muscle, and that compression continues long enough and is severe enough to actually develop nerve impairment, you get the same symptoms as you would in carpal tunnel syndrome, but then you get additional ones. So you get this because the nerve fibers that are involved are the same fibers that go through the carpal tunnel, but there are also the fibers that do not go through the carpal tunnel, so that you get involvement of the nerves to the muscles, the flexor muscles in the forearm, the deep flexors of the fingers and the superficial flexors of the fingers. so that the flexor digitorum become weak, so that you cannot flex the distal joints in the fingers. And this leads to a an inability, as we can see in this slide.
Go back.
Okay. Here we have an inability of making an OK sign because you can't flex the distal phalanxes of the index finger when you have a pronator teres induced muscle weakness. Also,
Have you seen the anterior interosseous syndrome often, Bob?
pardon? Oh,
Have you
how
seen
often?
anterior very often?
Well, it's interesting. The carpal tunnel syndrome occurs at some time in one's life in roughly 10% of the population. So 1 in 10 will have at some point in their life symptoms of carpal tunnel syndrome. Pronator teres syndrome is much less common. The statistics on that are much harder to come by. I've seen it said anywhere from 1/5, 1/10, up to as many as 1/2 of people with carpal tunnel will have a pronator. I think it's much more likely to be somewhere maybe 20% of people with carpal tunnel syndrome may have a coexistent pronator syndrome. You can also get pronator syndrome on its own. The statistics, the prevalence is much harder to identify because the syndrome is not identified as often. So the best statistics actually come from people who've looked for pronator syndrome in people with carpal tunnel syndrome. And in some studies, it's as high as 50%, but by and large, it's lower than that. Then there is a syndrome involving the forearm muscles alone, giving weakness to the flexor muscles of the fingers. And that's the anterior interosseous nerve syndrome, which at one time was thought to be a nerve entrapment syndrome by muscle. The pronator teres muscle can entrap that. The anterior interosseous nerve leaves the main body, the median nerve, below or distal to the pronator teres muscle. But recent thinking suggests that by and large, the majority of cases of anterior interosseous nerve syndrome arise because of an autoimmune disorder, a variant of Parsonage-Turner syndrome with the involvement in the brachial plexus rather than in the forearm. Although I think there are likely to be some cases, such as the one that Simeon has told me about, in which the anterior interosseous nerve was selectively involved as it went through the pronator teres muscle.
Here's an
So
interesting one for you, Bob. Based on what you've said there, Lawrence sent in a question saying that he's seen patients in the past who've been diagnosed with carpal tunnel syndrome by nerve conduction tests, but Tinel's sign was negative. Does that suggest that maybe it wasn't the carpal tunnel at all?
Well, if you do a proper electrodiagnostic study and show that there is a normal conduction time in the median nerve proximal, both motor and sensory, proximal to the carpal tunnel, and there's a delay through the carpal tunnel, then I would say that has to be carpal tunnel syndrome. If you do a median nerve conduction velocity test, and you stimulate the nerve above the median nerve above the elbow, then you do it below the elbow and then you do it below the pronator teres muscle, and then you do it across the wrist, then you can do a differential diagnosis. And it takes more time, it's more difficult. The clinical symptoms clearly come before you can identify slowing in electrodiagnostic test of nerve conduction velocity, so that the patient's complaint of symptoms is actually more than electrodiagnostic testing. A failure to obtain a TNAT sign, I don't know if that is weak. It's a gross physical sign. I think there may be variations. You may not be hitting squarely over the median nerve. By and large, I think patients' clinical symptoms are evident before any of these diagnostic signs can be elicited. So I put together a chart here, by the way. The top line is the top series of 3 X's is carpal tunnel. The middle with all the X's is the pronator teres, and the bottom is the anterior interosseous. And across the top, we have it's hard for me. We have pain. We have the sensory loss in the thenar eminence, which is only found in the pronator teres syndrome because the anterior interosseous nerve is only muscular and not sensory. The carpal tunnel syndrome has a sensory loss in the fingers and in the radial half of the index finger is indicated. Pronator teres has that, but also has a sensory loss in the thenar eminence of the hand. The last column, the last vertical column, has the motor loss in the opponens pollicus and in the abductor pollicus brevis, which is those muscles required in order to bring the thumb around it, so the tip of the thumb can touch the tip of the little finger. And that you find in the carpal tunnel syndrome, but you also find that in the pronator teres syndrome, because the pronator teres syndrome has basically everything on physical finding that you get in the anterior interosseous nerve and in the carpal tunnel syndrome. What the first vertical column has is the fact that the carpal tunnel syndrome pain complaint is largely nocturnal. So people with carpal tunnel syndrome complain of pain in their wrists, their hand, and their fingers at night. People with pronator teres syndrome and anterior interosseous nerve syndrome generally complain of pain. This is the second vertical column. Complain of pain during the daytime. And that is a useful clinical historical bit of evidence which helps direct us. So what this chart is an attempt to do is to help you separate pronator teres from carpal tunnel syndrome and anterior interosseous nerve syndrome. So the point I think that that Simeon and I want to make from this is that myofascial pain syndrome can indeed lead to nerve entrapments that mimic other neuromuscular nerve conditions. And if you learn how to palpate muscle and you learn how to treat this with trigger point dry needling, for example, that allows one to quickly treat these The treatment is both diagnostic because it tells you that you're right in your diagnosis, and it's curative. So, Simeon, you found this to be useful in your practice.
So, totally. Thank you, Bob. I mean, brilliant. One of the things that I've seen a lot, obviously, is this mobile phone use. People playing games and using their mobile phone and holding it up, pronating and supinating all the time. And I'm seeing more of that. I've certainly recently had a patient with a pronator teres syndrome which responded beautifully to the needling. I think, Stephen, what's really important is that, and one of the things that we're keen on in terms of education is really being able to identify the anatomy to a very precise level, being able to identify the taut band. And I think one of the great things with hands-on physical therapists is that we are able to fill these tight bands. I'm sure Bob will agree. And when we train MDs, they haven't got the palpatory skills. So in some ways, trigger points are one of the few platforms where an osteopath and a neurologist can sit together, and a physical therapist, and actually have a conversation about these things. And as you can see with Dr. Gerwin's knowledge base, that he's come to the whole trigger point story through that neurology setting, and I've come to it through the osteopathic setting, and we can have that conversation together.
Yeah, I have to say, some of my best teachers were physical therapists, osteopaths, and manual therapists who knew how to palpate. And you were quite right that allopathic physicians do not know well how to palpate, and certainly do not know how to palpate muscle.
That's encouraging for all of us.
Yeah, palpation, like when we work with the doctors, is not an active process. It's not about doing; it's about feeling. But sorry, over to you, Steve.
No, I was just going to say, Simeon, the knowledge of anatomy is really refreshing to see that in what Bob was just explaining. You've got very little time now. I've got 3 minutes left. The app that you've developed, as far as I recall, gives us a very good introduction to that, illustration of that, does it not?
Yeah, well, I think the thing is that what we've demonstrated already is that, this is a complex subject. And when you come on the courses, especially with the needling, and again, Stephen, when we talked about doing a needling course together, Stephen said, oh, we've had a few needling courses. What's different about yours? And I think it's true to say when we finished our needling course, you said this is nothing like what we've done before. And I think the point is that there is we think this is the gold standard. This is needling done by a neurologist who was head of pain medicine, if you don't mind me saying so, in Johns Hopkins for years. And this is a very different approach. And when you leave these courses, when you qualify with these needling techniques, it's very easy to forget what they are. These are complicated things. So we've developed this app together so that when you leave the course, you've basically got Bob in your pocket. Trigger points are a game changer, and knowing how to use them. Just to finish on this point, which is an osteopath, we have a limited toolbox, and knowing how to use IMS. Not only is it an efficiency in terms of treating and actually delivering treatment, and efficiency in terms of symptom relief, but it's a fabulous tool for the box.
Well, look, I mean, we've got to finish now, and I'm sorry that it's fantastic that you've got so much to share, and it's nice to leave people wanting more, I suppose. But look, Simeon, it's fantastic. Thank you for joining us from Tel Aviv. Dr. Bob, thank you for joining us from Baltimore. And I'm looking forward to seeing you back over here in May, because I think that'll be good. And it's very nice that you're sending your granddaughter to Cambridge to get some proper training as well.
Thank you for inviting.
Thanks.